metatarsal and are able to attach it onto that thumb. The second one is the great toe. It is essentially the exact same thing. The only difference is that you will be using the first toe rather than the second toe. The great toe wraparound, I think, is the one that's the most interesting personally. So you take the skin and the nail off of that first toe, but you leave the bone and you restore the toe with essentially primary closure. But then you take a piece of the ilium in your hip as a bone and you grind it down and you essentially make a bone for the thumb and use the skin base from the toe and wrap it around. And that gives you a new thumb. And it also retains the functionality of the foot by still giving you a great toe. And then the trimmed great toe is essentially the same thing as the great toe transfer. The only difference is that you trim down the skin in order to make it look a little bit more like the actual thumb. All of these are noticeable. However, they are less noticeable than for someone not having a thumb, and they restore the functionality of the hand. So this study is a case report of a 41-year-old right hand dominant male farmer, and he presented to the emergency department with a traumatic partial amputation of the left index finger and thumb at the metacarpophalangeal joint due to an incident with a table saw. He also had a partial amputation of the left middle finger 1 year prior. So this is an x-ray of his hand. His digits showed avulsion, crush injury, contusion, and the wound bed presented with crushed and avulsed neck neurovascular structures, dorsal skin avulsion, and necrotic muscle. And because of all of this, he was a poor candidate for revascularization. Essentially, the thumb was so torn up and at both the amputation site and what was left over that there was no possibility of reattaching the thumb or the first finger. So his primary surgery, he underwent a debridement of the bone that was essentially too damaged to reconstruct. And they did not do a primary closure. They just kind of left it open and closed it with Integra to keep it moist and allow it to heal slightly before they went forth with the second surgery. So this was a surgery that was done at 2 locations at the same time. So he had his foot prepped and his hand prepped at the exact same time. And the pedal flap, so the flap down at his toe, was marked, and they had to take into consideration the dorsalis pedis artery. And they chose to have the length of the thumb, the new thumb, to be about 2.5 centimeters in length. And then they opened back up the thumb, and they did an initial joining of the metacarpal and metatarsal with Kirschner wires. Many of you guys have probably seen these. If someone has a small break, they're just those very thin wires that will go up through the skin. And they use that as a guide for then cannulating the drill to create a hole between the metacarpal and the metatarsal bone so that you can use a nail. And the nail that they use measured 34 millimeters by 2.8 millimeters, which is fairly small. And that went inside of both of the metacarpal and metatarsal bone, and it joined them aligned very well. So they then had to reattach the flexor pollicis longus, extensor pollicis longus, and extensor pollicis brevis because the part of the bone that was removed in the hand would prevent the flexion and the abduction of the thumb. So they did extension of both of those tendons and reattached them to the end of the now new thumb. And then they advanced the volar plate, which I have a image of that there. And that's because the toe is a little bit more prone to hyperextension than your fingers. So with the advancement of that plate, you are now going to prevent the hyperextension of your new thumb and make it act a little bit more like your normal thumb. The next thing that they did was they did the neurovascular structures. So they used the dorsal radial sensory nerve and attached it to the deep peroneal nerve in order to regain sensation and innervation of the hand. And I have a image of where that is because I definitely forgot where my radial and ulnar nerves were. And then they also did an end-to-end side arterial anastomosis with the princeps pollicis artery to ensure adequate arterial and venous circulation. It was noted that this was one of the most difficult portions of the procedure due to the small nature of these arteries. And this is also one of the most essential portions of the procedure because not only does the bone need to have that blood supply, but also the tip of that now thumb. It is one of the highest rates of failure in these toe to thumb transfers is not having proper arterial anastomoses that will then eventually cause necrosis and possibly infection of the tips of that finger and eventually all the way down to osteonecrosis. So this is an image of the donor site prior to them obviously taking away his toe. They took it down all the way to 2.5 centimeters into that metatarsal bone. And the intermetatarsal ligament and extensor reticulatum were reconstructed in order to kind of bring together that first and third toe. And the Kirschner wires were placed to secure the bones and prevent splaying. These did not poke through the skin, which should be noted. Another great thing about this specific transfer is you retained so much of your foot functionality because just like your thumb, your big toe does play a large portion of the functionality in your foot, in your balance. So by using the second toe, this patient did have a very, very good recovery. Here is a photo of his post-operative x-ray. You can see that intramedullary nail between the old metacarpal and the new metatarsal, as well as some of his staples that they used. They were unfortunately unable to salvage anything from that first finger, and he does have that partial amputation of his middle finger. And so he did lose some of the functionality of his hand due to that, but we were able to regain a lot of the functionality due to saving his thumb. So his post-operative course, like I was saying a little bit earlier, that donor site from the second toe, he had immediate ability for weight bearing with absolutely no complications in the short term or long term. And by using the intramedullary nail, he was able to do active and gentle passive range of motion that allowed for hand PT on post-operative day 2. And he was able to start doing strengthening as tolerated beginning at 6 weeks. And he was fully back to work at 3 months. He did have to undergo a revision surgery just because there was some scar tissue preventing some motion. But this is in great contrast to using some Kirschner wires. You can go forward. So Kirschner wires, as many of you guys have seen, are very thin and they do bend fairly easily, and it creates a high rate of post-operative complications, not only because you have something that is entering the skin, so that's a high risk for infection, but you also have these very labile wires that are trying to hold together bone that is going to be something that is necessary for high functionality. So by having these wires in, you are required to have your thumb in a hard cast for an extended period of time in order to allow that bone to create the callus and eventually go through bone reformation to join those two bone ends. And by having those Kirschner wires in there and having your hand in a cast for so long, there can be some issues with the functionality due to your hand having to be in a cast for at least 6 weeks and then having to relearn how to use it on top of that. Whereas using the intramedullary nail is actually weight bearing at its beginning, which allows it to the bone to heal while not having to bear all of the weight. So the nail is going to bear the weight at the beginning, and then the bone will start to form around it and allow it to essentially heal while still being able to use the thumb. So there's also minimal splinting. As with this gentleman, he was able to start hand physiotherapy on day 2, whereas with Kirschner wires, you cannot start hand physiotherapy until about 6 weeks in, and you're in a hard splint until then. With the risk of pin sites, infections, and micro movement between the recipient and donor bone, the use of intramedullary fixation, I think, is going to be a great step in the toe to thumb transfer, because it's going to allow patients to return back to work within 6 months, unlike with Kirschner wires. And for children who are learning to use their hands for their first time, by doing these surgeries at a fairly young age, they get to use this new thumb as early as possible and don't risk any of the complications of possibly having a thumb in a splint for up to 6 weeks. And that is my sources. Does anybody have any questions? Nice and short one.
I have a question. That's
Yes.
pretty good presentation, Dakota. I really enjoyed it. So I know you talked about just like functionality being restored, and you talked about the neurovascular anastomoses and stuff. I'm not sure if in your research you saw any information about the sensation. Are there any complaints with the sensation? Like I'm sure it's probably not 100%, but are patients usually pleased with the amount of sensation they restore?
From what I've read, yes, particularly with the second toe to thumb transfer, patients do have a greater restoration and sensation from what I've read compared to especially the great toe wraparound where you're using the ischial bone. Patients reported a less, like, didn't regain as much sensation in that one. And I didn't read why, but I think it's because you're taking the skin off of the great toe and then wrapping it around something. So now you have things from 3 different parts of the body. You have your hand, the skin from the great toe, and bone from the ischium to all create a thumb. Whereas the second toe has all of that neurovascular in it. And the locations of where the nerves were allowed for a pretty good anastomosis. And there isn't a ton of sensation in the toes already compared to the fingers. So I think that's something that the patients would have to get used to because the sensitivity of your toes is less than the sensitivity of your hands. But there wasn't a high report of like neuropathic pain or phantom pain at either site.
Awesome, thank you.
I have a question.
Yes.
With regards to your last slide, do you think that I believe you called it Kirschner wires are going to be kind of like fading out, in kind of the future? Like where do they fit in versus intramedullary fixation? Can you kind of clear that up for me?
I think that in this specific type of surgery where you need the fingers to be load bearing in order to promote hand functionality, I think there will be a phasing out of the Kirschner wires in comparison to the intramedullary nails. But I think the Kirschner wires do still have a great use, particularly in like small fractures at the tip of the finger and other things like that. But with the pin sites as well as the micro movement in this, and it already being an open surgery, you already are having to do revascularization. I think it adds an unnecessary risk of infection on top of something that's already so complicated. Whereas with the intramedullary nail, you can have a full closure and mitigate that risk of infection, mitigate that risk of micro movement. So in the future, I do think that intramedullary fixation is going to be the gold standard for toe to thumb transfers.
That's great. Thanks for explaining that.
Has
Hi.
there been like any
Sorry.
reporting on like failure rates like with like graft versus host or anything like that?
Thankfully, because they all do come from your own body, I haven't read of anything of like a toe to thumb from a donor. They are coming from your own body, so there isn't a high rate of that graft versus host. The only rates of failure that I read about were due to neurovascular issues and loss of blood supply, eventually leading to necrosis.
I have a question. So you said that like a good portion of the thumb was they weren't able to save it. I recently was reading about this method that they put basically they graft the thumb or any part of the hand inside the abdomen. So it's like abdominal pockets method of like revascularization, something like that. So they put the hand inside the abdomen to basically like regenerate that vascularization. Do you think like they could do that first to save more portion of the thumb and then do the transfer? Like, is this something that like they do? I'm not sure.
I think in this specific case, it wouldn't have been an option because his mechanism of injury was with a table saw. And so there was like very, very extensive damage to the phalanges, the two that he lost. So I don't think that they would have been able to revascularize it just because there probably wasn't much left of the thumb. But in a case where it is a more of a clean injury and the remainder of the thumb is still salvageable, I think that would be a wonderful idea. It just wasn't applicable to this case.
Got it. Thank you.
I had a quick question. A great presentation, by the way.
Thank you.
Very interesting topic. Maybe you mentioned it in the beginning and I didn't quite caught it. Did these patients after surgery undergo any type of like physical therapy for rehab on the thumb?
Yes, there is extensive physiotherapy and occupational therapy required for these patients because you're essentially having to relearn how to use your hand. You've just added what your body considers a new joint. It is a little bit shorter than someone who, say, had a muscular injury where they're having to regain all of the strength in the muscle because your brain does still remember how to use those muscles. They've just become very weak and they were injured. But this patient in particular underwent physiotherapy for 6 months before he was released, and he did have a very accelerated course. Most of the other papers that I read with the Kirschner wires required at least a year of physiotherapy to get up to 75% of hand function.
Thank you. Thank you so much.
I had one more question. I know you mentioned about having patients having to return to the OR because of like scar tissue. Is that the most common reason for them returning, or is it more like the neurovascular stuff?
Most of the requirements to return back to the OR were due to scar tissue, and this patient had scar tissue, and I think, in my opinion, is just because of the extensiveness of his initial injury that there was a lot of skin and fascial scar tissue. Some of the more clean cut injuries, even with Kirschner wires, didn't require scar tissue reformation surgeries, but they are a little bit more common with the Kirschner wires due to the amount of immobilization that they need.
Makes sense. Okay, thank you.
That was a really great presentation. Thank you so much.
Thank you.
Any other questions? Okay, we'll move on to our general meeting. Let me just stop the recording real quick.